Our branch has a passion for helping those in the face of complex pregnancy challenges, and he cares for his patients experiencing high-risk pregnancies. As a specialist in maternal fetal medicine, Dr. Brandt specializes in managing various conditions, including recurrent miscarriage, genetics, and fetal diagnosis and stillbirth. He is committed to achieving the best possible outcomes for his patients and is here to support you and your family every step of the way through pregnancy journey. I was asked to present something like personally. He's a man of few words, I think. But I did have the privilege of being shoved in a van with this man for an entire few days in Sri Lanka chasing elephants across, and we really got to know each other well. So it's all yours. Thank you for all that you've done with patients throughout the years.
As I say, I'm always doing my job.
Thanks a lot.
You are.
Yeah, right. Can you hear me? Are we okay if I stand here? All right. I want to tell a story. That's why I'm here today. And it's a story about fetal loss. And it's a story about other complications of pregnancy. But most importantly, I think for this audience, it's a story about how investigative efforts can ultimately lead to solutions. So I want to tell that tale today. How do I change the slides? I don't know.
Push on the...
Push on.
I'll do it for you here. Sorry.
I can do it here. This is great.
Oh, there we go.
Yeah,
Just page down, yeah.
these are disclosures, and you'll see what that's about in a minute. So, a long time ago, not in a galaxy far, far away, but a long time ago, I was told to get engaged in a certain newly recognized complication of pregnancy that ultimately became known as antiphospholipid syndrome. And it was in the early 1980s that this autoimmune condition was recognized as being associated with fetal death, that is stillbirth, as well as with some other medical complications, including blood clots. International conferences about this condition started in the early 1980s, and I have attended the majority of those, most recently the 18th or 19th in Japan a couple of weeks ago. The name of this condition, as it's now known, antiphospholipid syndrome, was bestowed upon it in the early 1990s. There is our first publication regarding our management of a small number of cases to prevent or to ameliorate pregnancy complications. And so that's how we got started in this condition. Let me make sure I'm not missing a slide here. Yeah. Ultimately, in the late 1990s, the condition was classified by experts. So criteria were developed so that you can name the condition. And the criteria at the time, devised by a group of experts together in Sapporo, Japan, included either having had a blood clot in the past or an obstetric morbidity. And on the slide there, you see the obstetric morbidities. They are recurrent early miscarriage, otherwise unexplained fetal death at or beyond 10 weeks gestation. That, of course, includes stillbirth. And placental disease, preeclampsia, or placental insufficiency requiring delivery less than 34 weeks. So we came up with those clinical features. There are marker autoantibodies. I'm not going to talk about them much today, but there are marker autoantibodies for this condition. And if you want to keep the slides and look at them, you can. We remained involved in the investigation of this disease. We participated, I and a couple of my colleagues participated in a small randomized trial of steroid treatment during pregnancy versus low doses of heparin during pregnancy in an effort to prevent complications, including stillbirth. And it was the result of this trial published by first author Susan Kalchuk, you see, who, by the way, is now a rabbi. How about that? We participated in this, and the standard of care became the heparin plus the baby aspirin treatment. And we're going to talk about that a bit more in a minute. I also worked on intravenous immune globulin treatment as it might pertain to improving outcomes in this pregnancy. Yeah. And that study was negative, as were a couple of other studies done by others. And that is feedback. Am I doing it? No? Okay. All right. And that proved to be negative. So the standard became the heparin and the low-dose aspirin. Here's a classic case. This is it's a case of mine in the last couple of years. 27 years old, first pregnancy. And at the time, for the sake of the presentation, yeah, that's a good idea. Yeah. Don't lose that thing because they're expensive. So, the 27-year-old, 26 weeks gestation, she has a previous diagnosis of antiphospholipid syndrome because she had an unprovoked blood clot in the past and she has all the marker antibodies. She's treated during the pregnancy, thoughtfully, I think, by the folks taking care of her with low molecular weight heparin, which is the modern day heparin compounds, and the baby aspirin, low-dose aspirin. And she's been treated since early pregnancy. So now she shows up with features of severe preeclampsia. She also has fetal growth restriction and all of the features that we can identify ultrasonographically of a failing placenta. And if we left things alone, what would happen to that fetus? It would pass away in utero, and it would ultimately be a stillborn. Having identified the condition, the team of care providers said, this is a bad problem, we got to get the baby out, and we did so, and a 26-weeker was delivered. I want to make the point that this situation occurred in spite of the standard treatment, and what has emerged over the last couple of decades is that the standard treatment is not quite as good as we want it to be. Our team participated in this study run by Jane Salmon in New York. And in this prospective observational study, we followed patients with either lupus or this antiphospholipid syndrome, or both, and some controls. We followed them during the pregnancy. We didn't tamper with the treatments. Their care providers treated them, typically, if they had antiphospholipid syndrome, with the heparin compound and the low-dose aspirin, right? And we did a bunch of patients. And so what we found, I'm not sure I can point. Can I point to this? Do you see that? Yeah. Oh, yeah. What we found is we enrolled 496 patients ultimately, which was not bad in my view, given that these are relatively infrequent conditions. And in those 496, there were 21% of the patients had an adverse outcome as defined at the bottom of the slide. And that adverse outcome could be a fetal demise or a neonatal death due to complications of prematurity. And what we found was that the adverse outcomes were best marked, I should say, by the presence of one of the autoantibodies that's known as a lupus anticoagulant. I think it's a stupid name, but that's the name of the antibody, sorry. There you go. And the red bar there represents the adverse outcomes on the y-axis. The red bars are the ones with lupus anticoagulant. So it turns out that in this condition, which is characterized by clinical features, including prior stillbirth, the worst marker is this lupus anticoagulant thing, and it's one of the autoantibodies. So what we have found is that patients that don't have the lupus anticoagulant and who get treated typically with an aspirin and a heparin compound do pretty well. And that's great news. But those people that do have the lupus anticoagulant have a suboptimal pregnancy outcome around 40% of the time, in spite of this standard treatment that was sort of designed, started in the 90s. So, what do? Patient comes to see you, like the last case, the one I showed you, 26-week pregnancy delivery to spare the case from stillbirth, so to speak. Patient wants to have another pregnancy. What do? Well, over the years, we have tried a whole bunch of stuff sort of empirically. And by the word empiric, I mean we thought we would just try something, right? And that happens to be a fair amount of American medicine, let me just point that out. But well-designed trials were lacking. There has been promulgated a mouse model of this condition that was used to come up with some ideas. And in the mouse model, the pregnant mice were injected with serum from either a healthy person or serum from an antiphospholipid syndrome person, so that the antibodies are now in the mouse. And doing that creates a model wherein pregnancy loss is pretty common. And remember, the mice have multiple pups, right? And it turns out that in Dr. Salmon's lab at Cornell, in that mouse model, if you block in the inflammatory response, the ability of that mouse, by various mechanisms, you block the ability of that mouse to generate inflammation at the interface between the mother and the placenta, the APS doesn't kill the fetuses. Now that's kind of cute. That's kind of neat, isn't it? Now, I think the mouse model has its problems. The mouse model was originally described here at the University of Utah, by the way. I think it has its problems, but this was the existing evidence. Dr. Sam, in Jane's lab, she and her colleagues showed that an initial event in the murine model, an initial event is complement activation, that is an immune activation at the interface between the placenta and the fetus and the uterus. And part of that cascade, remember, inflammatory cascades are complicated, they're not really simple. Part of that cascade is the elaboration of TNF-alpha, that's tumor necrosis factor alpha, and the accumulation of white cells in the tissue, in the placental tissue. So inflammation is going on, is the point, in this mouse model. And Berman, her people showed that if you block the TNF, and there are agents available to block TNF that are used for rheumatoid arthritis and Crohn's disease and psoriatic arthritis and that kind of stuff. If you block the TNF, you also improve the pregnancy outcomes in these mice. Now that's a good thing to know, because TNF blockers are out there and they're FDA approved for certain autoimmune diseases. Now all of this information was available in the late 1990s and early 2000s. So one day I had a patient who had previously had a mid-trimester stillbirth, and and that was in spite of treatment with the heparin compound and the low-dose aspirin. And this was a well-informed and bright patient, and we talked about things. And this patient, I guess the right word is, insisted on another pregnancy. She'd never had a child. So at the time, there was one TNF blocker on the market, and we talked about that, and we decided to give it a shot. Now, I don't want you to think that we're totally nuts here, because the TNF blocker, this one, had been used in pregnancy before, but in patients that had rheumatoid arthritis or Crohn's disease. So we weren't just completely nuts. So I did that. We did that. And she has 2 kids. And that's a great thing, and she shows us pictures of them and that kind of stuff. But that's an N of 1, and that's not a study. So what we did then, Jane Salmon and I got together and had 2 glasses of wine, and that's the key thing here. That's the key thing. And we said, we got to do this thing. So we put together the IMPACT trial. This was over a dinner in Atlanta, as I recall. And it was a long time ago. And so we hypothesized that if we added TNF alpha blockade to the standard treatment, we could reduce the rate of adverse outcomes as defined on the slide, the primary outcome. You see it there, guys? We could reduce the rate of the adverse outcomes by 50%. Now, when you sit down to design a study, you make up some numbers based on your best evidence, to be sure. And so, to a degree, we kind of made up a number, 50% reduction in adverse outcome. And then we wrote a grant, and then we sent it to the NIH, and we sent it to the FDA, and we did all the things you do. And we got approval, and we got some money, which is really key here. Please, no one in this room forget that about further studies in stillbirth. Please do not forget that. And Jane in particular is an excellent fundraiser who's really well plugged. She's a senior rheumatologist, and she's really well plugged in with, say, the Lupus Foundation of America and others. And the pharmaceutical company helped us a lot, and I think we're indebted to the pharmaceutical company. It's a rare disease study. It's a single-arm trial. Everybody who's in it got the drug. We had historical controls from the PROMISE study. Remember the ones where we just watched to see what happened? And so we decided to do it this way, and we could talk forever about study design. We're not going to do that. You had to be pregnant. You had to have the lupus anticoagulant, that bad marker. And we started the study, and we got patients from around the country. And a slight majority of the patients are from Utah, but quite a number of them from the New York area, and Jason and I at Michigan, and some other players that helped a lot. Well plugged in hematologists, rheumatologists, and MFMs. I'm an MFM. So, what we did was we screened 76 people, we enrolled 51 people. So we started with an intention to treat group, as they call it, of 51. And in the next box down, second up from the bottom, you see the modified intention to treat group. And that's the group we're primarily going to discuss very briefly anyway. The reason there's a modified intention to treat group, as you can see to the right-hand side, there were some patients who enrolled who lost the pregnancy in the first trimester, miscarriage. We did not think we were treating miscarriage, so let me be clear on that point. And people do have miscarriages, right? And then some of the pregnancies were lost because of genetic abnormalities, and these are what are the words? Standard, well-known genetic abnormalities that can cause fetal death. So we didn't include those people in our analysis of the study outcome, right? Does that make sense to everybody? Okay. So I want to characterize the patients a bit to let you know that it's a very high-risk population. So almost 20% of the patients had lupus, and 70% of them had a history of blood clots. So this is not a benign population of folks. And you can see, though 88%, third from the bottom, 88%, I should use the pointer, shouldn't I? 88% had a history of obstetric morbidity that's characteristic of antiphospholipid syndrome. And so this is a high-risk population. The most important part of this slide is right here. A history of a live birth surviving to hospital discharge. Under 40% of the patients in the study had a baby. So it's a high-risk group. This immune condition is a problem. So here are the primary outcomes from the trial. This is published a few months ago. And in the middle one, third over from the left-hand side, the modified intention to treat group, of which there are 45 patients, the primary adverse outcome rate was 20%. So 80% of the patients did great. So we were thrilled. And that met our statistical goal of a reduction from 40% to 20%. Now, there's no such thing as a perfect treatment for all disease, that's for sure. And one of the patients in the 20% category had a classic antiphospholipid syndrome stillbirth. But many patients had their only baby as a result of this trial. So we were thrilled. And we're carrying on with that. We still can enroll patients thanks to the pharmaceutical company. As you may know, the federal government is not working anymore, so we don't have any money from them. So, by comparison to the old patient populations, that first column, second column from the left is our adverse outcomes in the 45 patients. And so the adverse pregnancy outcome rate and the impact prior treated pregnancies, that would be the impact eligible prior treated pregnancies, would have been 69%. 70% of the time those patients had an adverse outcome compared to 20% with the treatment, and so forth. I won't belabor it because I want to get on to something else. The idea that immunomodulatory drugs might improve pregnancy outcome has made the news in a different sort of way other than the IMPACT trial, and I want to bring that up as something that you should perhaps know about. So one historically well-known cause of stillbirth is alloimmunization to red blood cell antigens, Rh disease, right? And so for eons, people have noticed hydropic stillbirths. They didn't understand what it was about, but it's been described for thousands of years. I think probably 3,000 years, actually, because it had to be written down. Right. So anyway, and here on the slide, you see what the mechanism is. That in this case, we're talking about an Rh negative mother, upper left-hand diagram. And the mother bears a child that's Rh positive instead of being Rh negative, right? And during the pregnancy or at the time of delivery, the fetal blood cells get into her circulation, and she makes antibodies to those red blood cell antigens, to the Rh positive antigen on the blood cells. So in a next pregnancy, she's making these antibodies that cross the placenta and attack the baby's blood cells. And that's how the Rh disease works. Now, it turns out that there are other red cell antigens besides those in the Rh group. That's not the point of this conversation. I just wanted to give you the example. Ken Moise recently published in late 2024, a study of nipocalimab, a monoclonal antibody. Remember, I'm using a monoclonal antibody called certolizumab in the IMPACT trial. It's an immunomodulatory antibody. This also is an immunomodulatory antibody. And what it does is when you give it to a patient, it dramatically drops their antibody levels, their IgG isotype antibody levels, to about 35% of normal. And so the concept here was that Ken wanted to take patients who had bad outcomes from horrible alloantibodies that had previously resulted in pregnancy loss. And so you can see in their most recent qualifying pregnancy, live birth rate was 38%. So that's a high-risk group. And all of this due to the antibodies to the red cell antigens. In the study, he gave everybody the nipocalimab, and the IgG levels fell, including the antibody levels that were causing the trouble, right? And in the study pregnancy, 92% of the patients had a baby. So it's also a single-arm trial like ours. Different disease, but antibody-mediated disease. Does that make sense to everyone? So thank you for listening. I wanted to talk about successful investigations in the arena of stillbirth. Thanks. Yeah. That's it.
Does anyone have any questions that I can?
Go.
Brenda.
You said there's the funding may stop, but is any research still going on with this?
Yeah, so for our work using certolizumab, the drug company is continuing to fund additional recruitment. So that's very generous of them. Now, remember, the drug companies, they kind of have one thing in mind. And so that's just the truth. Dr. Salmon and I are meeting with them in 2 weeks at the American College of Rheumatology, meeting in Chicago. And what I want to do is, that company also makes one of these FcRn receptor blockers, like the drug that Dr. Moise used. And I'd like to get hold of some of that and see if giving that agent would reduce the lupus anticoagulant levels in the patients before they conceive. I like that idea. And then that might be as good or better a treatment compared to the Cimzia, or maybe you use both together. But, so that's the answer to the question, right? But everybody in the room should remember to support investigative care, because that's how you learn to fix things. That's the message. Yeah.
Go ahead first. I know one of the frustrations within the loss community is that criteria of having to have 3 losses before you're getting screened. Is there any changes coming to that, to where we can change that screening criteria to not have to lose 3 babies before you can care?
So the professional organizations that write about recurrent pregnancy loss include the European Society for Human Reproduction and Embryology. That's ESHRE, if you want to write that down, all caps, because their guidelines are free online. And then there's the American Society for Reproductive Medicine guidelines. And both of those sets of guidelines promote evaluation of patients with 2 miscarriages as the starting point. So I think if you were to come to see Dr. Silver or one of us in our group or me, we're going to evaluate patients right off the bat if they've had a second miscarriage. Now, we could talk for a long time about miscarriages, and I'm happy to do so outside this room and so forth. But I think we're not waiting for 3. When you write classification criteria, like you saw in the Sapporo classification criteria that I showed, please remember that the reason for that has to do with research investigations more than with face-to-face clinical care. And that's important because you don't want to, how do I say this? When you classify patients for studies, you want to be creating a relatively homogeneous population and not grouping a whole bunch of different kinds of cases together, because then you confuse the outcomes that you're measuring. And so classification criteria are different than professional guidelines for clinical care, or different than face-to-face interactions with patients. Does that help?
Yeah, just in my experience, I think a lot of the parents here would say that many parents have had that clinical experience, so having to have 3 before.
Nah. The rules are, the guidelines say 2 for clinical care. Classification criteria, different problem, different issue. Yeah.
There was one more question.
Yeah, how do patients get diagnosed with APS? Is that for regular prenatal blood draws? Is this?
So typically the patient goes to see a doctor because of a blood clot or a stroke or some medical malady or severe preeclampsia, stillbirth, and the informed clinician says, oh, this could be antiphospholipid syndrome, I'm going to do the tests. That's how it usually works. So
you're only going to catch it if they have a problem.
That is correct. A frustration to be sure, but that is correct. One interesting aspect of what you brought up is, at a study we did here some years ago, Karen Gibbons is the first author, we drew blood on all the patients that would allow us to draw blood who came in with preeclampsia or placental insufficiency with severe features. to the labor and delivery area. And 11% of them are positive for antiphospholipid antibodies. And so one way of perhaps preventing a next pregnancy bad outcome is to think about your presentations even in a routine setting, like an average labor and delivery room suite. And if the patients have these features that raise the possibility of antiphospholipid syndrome, test them. So that's our tendency here, of course. These are not terribly expensive tests. That's an important point. Yeah.
I was just wondering, on your outcome-based slide there that showed improved number of live births, do you have more information to share on the percentage of those that were premature babies and at what gestational age? Because that outcome for families is obviously...
I don't have it in one of these slides, and I can't remember the exact number. So there were 6 cases of preeclampsia requiring delivery before 34 weeks, which is, I don't think, ridiculously unexpected in this high-risk population. And then of the cases that went beyond 34 weeks, most of them went to 36 plus weeks, but it's a patient population who is sitting there with their doctor in, name a town somewhere, and everybody's so anxious at 36 weeks that there's a lot of iatrogenic early delivery going on too. And it's really hard to characterize those other outcomes in terms of the need for a delivery prior to, say, 39 weeks.
Yeah, thank you.
And you can imagine how that might be the case.
I'm a mom of 3 preemies. Yeah. 36 weeks gestation is a very good gestational age with a preterm birth.
The mean gestational age of delivery was like 36.7 or something like that. I can't remember the number. Okay, I'm standing between you and lunch, guys.
Thank you.
Yeah.
Thank you guys very, very much.